everyone. I'm Alana Ross. I'm the team lead for the project of coming up with a plan to prevent pressure ulcers in long-term care. As you can see from our standard work combination sheet, there will be 3 of us presenting today for a total tap time of 15. Here we are. So this is our team. Our team members consisted of our sub-team lead, Annalie Stuckel, that's me, team member Tracy Hobson, and team member in KPO support, Anton Canitz. 2 of us will be presenting in person. Anton is joining us by phone from his new position in Saskatoon, and Annalie is on a vacation in Hawaii, so will not be able to join us today. So this is our mistake proofing project form. So as you can see, we've been tasked with trying to eliminate pressure ulcers for long-term care residents. And our current situation, we noticed that there were several things that we needed to look at. The major thing is we're dealing with a very vulnerable population who have chronic comorbidities. We were on Paradise Path in her Bassett Home, which is a cognitively impaired unit. So that impacted as well. There was a lack of actual standard work in place. There was numerous areas for documentation. We found as many as 12 areas where there could be documentation on wound care. There was a wound care binder that had been compiled by the previous long-term care assessor. Some really good information, but very hard to find because it was so detailed. And some of the staff that we spoke with weren't even aware it existed, and all indicated that they didn't have time to look at it anyway because it was just too detailed. One of the things for treatment of wounds, at the time we started the project, they had a very cumbersome wound care cart that had to travel a great distance and was packed with a lot of supplies. And one thing we want to make note of is this is a very caring staff, and all we're really looking forward to having improvements made. So this is our current state map when we started the project. And as you can see here, there's several starbursts or area of improvements. So one thing that we noted in speaking to the RNs was the MDS tool that they used, they felt wasn't accurate for a variety of reasons. Again, as I mentioned, there was no standard work around the turning and repositioning protocols. As you can see in our data box, there's a total of 48 residents, and there's 1 RN or LPN on 16 to 24 hours a day, and that person is expected to do all of the assessments and all of the treatments. And then our 8 CCAs who work 12 hours during the day, and then at night there was only 4. Okay, so this is our Virginia Mason mistake proofing assignment. So our defect is our redness turning into a pressure ulcer. When we started the project, we were at a current mistake proofing level of 2 with a defect rate of 29. So just skip that. Go to data. So this is some of the data that we collected at the start of our assignments. So what we had here, what this shows is when clients are admitted, an assessment was done, and staff were consistent at doing that. But what happened is, because of various reasons, one including time restraints, subsequent assessments weren't always being done. So, and it also shows us that residents acquire wounds on the units, but they also come to the units with existing wounds. And this data indicates to us that the majority of the wounds that we did see on the unit were actually stage 1. They hadn't progressed to the point of being a full pressure ulcer. So this is our target progress sheet. And one of the, so we focused on the wound care cart, which was our 5S project. In the beginning, we had that big wound care cart, which took a total space of 6 square feet. The nurse had to walk a significant distance, 126 steps, and push the cart a distance of 117 because they left it outside the door of the unit. They didn't take it into the patient's room. Our goal is to reduce that, and for our repositioning, our baseline, we would be able to turn and reposition 10 residents in a 2-hour period, and our goal is to increase that to 24.
Oh, the down one. So these are some of our idea summary sheets, and as she said, we talked about the charting system and that we found many different places to do that. We had looked at 5S'ing that, and then we decided that was way too big of a project for us to do in this scope, so we are leaving that hopefully for a future RPIW. And again, an idea sheet around the inconsistency and the accuracy of the MDS. So further teaching and written procedure for MDS training needs to happen in the future as well. And this is just a picture of the wound care idea sheet around that. It was not up to date, not stocked adequately. So what we wanted for measures taken was individualized wound baskets for patients that require those dressings and having them readily available in the patient's room. And this is our spaghetti diagram around that, just showing that the feet walked, as she said, was 126 feet to go from the desk to get the wound cart and then go to the resident's room. And then following that, once we've implemented that change, of course, now we've eliminated those steps of getting the wound care cart, and it's just basically going to the patient's room to provide that service. And that's just the picture of the wound care supply basket that her Bassett staff put together. So I believe in each room that the residents require, they've got their supplies readily available at the bedside now. And another idea we had, when we were trying to find out the high-risk patients, which is what we focused on in this project, it's not clearly identified who are the high-risk patients for developing those ulcers. So I'm going too fast now. It's okay. So we just wanted an indicator labeling patients in the rooms for the need to be repositioned every 2 hours, because best practice is that every 2 hours these patients are repositioned. So we had to come up with something that's easily identified for the staff, that they know, just to trigger that those are those patients that they need to address every 2 hours. So here's a picture of what we have come up with, and we've put this in on every patient's room. So at a quick glance, they can walk by and go, these are my patients that are at high risk. We had also tried thinking about something that could travel with the patient, with the clock or something indicating, every 2 hours we could reposition these patients, but for infection control and other reasons, that idea was kind of scrapped. And again, as she spoke in one of our starbursts, inconsistency in the O2 referral process was happening. So we've tried to implement something that if there's a PER score greater than 3, it automatically triggers that referral to OT, which then will result in an improved care plan for each of those patients. So it's just individualized. So it's not quite so cumbersome for the staff, so they understand what they need to do specifically for each patient that are at these high risk. So with that, we've implemented some standard work around the management and then just what triggers that to happen. So if somebody comes out when they're first assessed, they've got this PER score greater than 3, then that O2 referral just automatically is put into place. And here's our multiple skill training checklist, which just fly through that, which shows we've got just a few people in management that we have to train in that process. And another idea that we came up with is there's no identifier on the assignment board as well for the CCA. So now when they come in the morning, they're just going to be highlighted on the board, those high-risk patients, so they know right away at a glance that those are their high-risk patients that we were trying to focus in this. We had thought of something that we could do for the staff that, every 2 hours they're cued, time flies when you're having fun and busy at work, and those 2 hours pass. What could we do to kind of trigger that, okay, we need to get on it and do our rounds? We thought about music, and we'd asked, if we could pipe in music, and so then nice little jingle happens every 2 hours. But they didn't think that was a really good idea with the residents that were on that ward. They thought it'd be too distracting. So we didn't do that. So we didn't want to cause a problem. So what we came up with instead was some timers that are on order, and basically you could just set these timers at the beginning of your shift. Every 2 hours these timers are going to go off. These care aides are going to carry these timers with them. So in that 2 hour, when it goes off, they know, okay, I have to make sure that I'm getting on my round and addressing these patients. And And these are just the pictures of the timer that are coming. So with that, there's standard work surrounding the residents at high risk and the highlighting and all that. And we have started some of that training with the care staff, and as you can see, there's quite a few we have to get through. So we did do some time ops forms following that. We didn't have our timers, but we did go in and they used their phones, which they could set for timers. So we did do some timing. And one of the things that we had with the staff was which we have to do some more training and stuff. When we say training and positioning, they're thinking it's a big lengthy process, which is why we want these care plans in place. It's not necessarily a big turning and positioning, it's just offloading, it's a reshifting. Once that kind of education is going through, they know, it shows here very clearly, when the alarm goes, they go to their patient, they do their repositioning, and they move on. It takes a very short amount of time, but we're addressing the offloading, the shifting of that red and sore area. Anton, are you awake?
So this is our future state Valley Stream map. Because we don't have the actual timers yet, it's not entirely in place yet, but as you can see, we've addressed many of the starbursts, and the other thing we've allowed is that the repositioning oftentimes only takes about 15 seconds because now they're not expected to, or they know they're not expected to do this full transfer or anything like that. So you'll notice that our cycle time has gone down quite a bit from that, but they're actually repositioning more often, and yeah. Next slide. So this is our post for the target sheet, and you can see we have a lot of 100% changes, mostly because we either completely eliminated certain items and added certain things. So there actually is a set repositioning frequency rather than just things like when they're repositioning for transferring to toileting and for bathing and stuff like that. And then we developed care plans. We've eliminated a lot of movement because now they can just do any wound care as part of their regular flow rather than having to get the cart or anything like that. And so they completely eliminated the cart. And then the setup associated with that cart has also been eliminated. Next slide. And so, back one. Okay, and so you'll notice that our capacity shot up a ridiculous amount, but that's entirely because now they know that the actual expectation of repositioning is quite minimal, so they have plenty of capacity now to reposition all the clients that we need, all the residents that we need to. Next slide, please. And so this is our newspaper, so you can see we still have some items still outstanding. So we have most of the plans in motion, they just haven't fully been implemented. So it's mostly a matter of training and just catching up with the new standard work that we've implemented. Next slide. So the summary, we have an actual process now that's quite clear and relatively simple for people to follow. And then we've added some visualization, and there will be an audio add-on for queuing us for those patient at-risk residents. And then we also have worked extensively with OT to make a system that makes a lot of sense to them. And we 5S'd something that I think they wanted to do anyways, but it was just an extra suggestion, so that was implemented quite quickly. Next slide. So we do have some next steps because we didn't get all the items in place that we wanted to by this time. So we will continue to educate staff, and once we get the timers, make sure that that's working effectively. And so as part of that, we'll do follow-up audits to make sure those timers are actually working effectively, to make sure our residents are being repositioned as frequently as they are needed. And then time observations will help show if we've actually achieved our future state that we've written out. Next slide. So we have thank yous to Frank. He's been very helpful and helped implement some of our ideas without us even having to be there. So that was a surprise for us a couple times where we walked in and it was already done. So that was nice. And so, to the staff on Paradise Path, they've been great to work with and giving us lots of feedback and ideas. Ron for working with us on the care plans. Nola, again, similar thing, helping us a lot in that. And Eddie, Terry, Pat, John Black, thank you all. It's been good. I think we're done.
Awesome. Thank you.